It's 5:58.
It's 6:01.
That
It's 6:01.
and more young patients, and that they usually have a signature carcinoma, histopathology which is poor in prognosis, and a more patient presenting with advanced stage. The colorectal cancer is divided on the basis of immunohistochemistry report in the three molecular subtypes. One is epithelial, mesenchymal, and a hybrid variety. These actually both epithelial and mesenchymal components both are present in the hybrid types, subtypes. The epithelial types of a colorectal cancer are usually cateterine positive, nuclear enzyme B catenin positive, but negative for vimetine. This subtype of colorectal cancer has a less propensity for a regional lymph node involvement, as well as these tumor subtypes have a low mitotic load that indicates the epithelial subtypes of a colorectal cancer usually have a good prognosis. And contrary to mesenchymal subtypes, a colorectal cancer of a mesenchymal variety is having reports immunohistochemistry E category negative, negative for beta catenin, but positive for vimetine. They show high rate of mitosis, high nuclear cytoplasmic ratio, higher propensity for regional lymph node involvement, henceforth show poor prognosis. On immunohistochemistry examinations, the slides we look for, a block we look for the genetic epigenetic alteration. I have already told the MMR, mismatch repair, BRAF, KRAS mutations. So let us go one by one. The mismatch repair is a protein, is a nuclear enzyme which participates in the repair of base-base mismatch that usually do occur during DNA replication. So this MMR is usually in common colorectal cancer. Among 10% cases, they are altered or mutations are there. And during the cell proliferation, if MMR is having a mutation, so you can understand as a result of DNA hypermethylation that lead to the, I mean, non-repair of a base repair and lead to the worst outcome. So the MMR genetic alteration in colorectal cancer, you can see germline variants are 2 to 7%, in somatic variants 2%. And overall, if you see the colorectal cancer, the MMR deficiency is seen in a 9 to 10% cases. The BRAF mutation explains a very poor prognosis for colorectal cancer patients. Median survival just limited up to 1 year. This is very aggressive, almost highly lethal colorectal cancer. Those who present with the BRAF mutations. BRAF is basically a proto-oncogene, and it is found usually like MMR 10% cases of colorectal cancer. Furthermore, notified should be noticed that the BRAF mutation is more commonly associated with the right side of the colon and less commonly with the left side of a descending colon. They exhibit higher rate of mitosis, higher nucleocytoplasmic ratio, higher grade of histology, higher content of mucin in the tumor. These all are unfavorable factors. So more commonly associated with peritoneal metastasis. In view of all above features, make the BRAF mutant colorectal cancer patients a very poor outcome of disease. The third in the row is the RAS mutation, KRAS mutation. The RAS is basically three isoforms, and the KRAS is one of them, and being most commonly associated with many cancer. The human KRAS mutation found almost 25 to 30, 40% is data is shown in the slide is little less. Actually, it is basically a 25 to almost 35 to 40% among the colorectal cancer patients, and a KRAS mutations with altered gene found almost 30 to 40% cases. And a different cancer is 17 to 25% is rated. So KRAS mutation in the colorectal cancer, so that KRAS is more common in compared to KRAS, in compared to MMR, in compared to BRAF. Those who are limited up to 30% cases only. But the KRAS is more common among colorectal is almost 30 to 40%. The KRAS mutation in colorectal cancer associated with poor survival, increased tumor aggressiveness. So it's also a poor prognostic factor. The patient, those who are having a KRAS positive and left-sided colonic cancer, European Society of Medical Oncology suggests the FOLFOX plus anti-epidermal growth factor receptor, the cetuximab. This provide the it's a monoclonal antibody provide a good result against the surface antigen. So FOLFOX along with the anti-EGFR provides a good result more commonly towards those patients who are having a KRAS positive and left-sided colon. But however, the patient with the KRAS positive but having a right side of colon cancer, the right side colon cancer is more dangerous, that we have they usually present in the advanced stage more commonly, and ISMO suggests the FOLFIRI plus anti-vascular endothelial growth factor bevacizumab producing a good result. So for metastatic colorectal cancer with KRAS positivity wild type means there is no mutation as such. The chemotherapy is cetuximab plus sulfox chemotherapy, and a BRAF mutant patient recommended the FOLFIRI with anti-vascular endothelial growth factor. FOLFIRI compound oxaliplatin, leucovorin, 5-fluorouracil, irinotecan, as well as bevacizumab drug. So the conclusion we can say the last decade of colorectal cancer molecular research has produced an important amount of data And in order to personalize the treatment for colorectal cancer, it is necessary to understand the natural history and malignant genesis of mechanism that help to the disease progress. And unique biological signature of a colorectal cancer can be distinguished by identifying the biomarkers expression after the surgery, sending the blocks into tissue for this immunohistochemistry or FISH technology studies. Several markers show potential individualized approach. Studies based on the particular disease characterized will pave the way of personalized medicine, personalized chemotherapy for each disease stage apart. Therapeutic management based on the biomarker testing result will allow better use of healthcare resources and may relieve the patient from unworthy, unnecessary chemotherapy, non justifiable. Thank you very much for this lecture. Jai Hind.